informative, packed show, and I do try every week to talk about things that are pertinent to the community in regards to health in this wonderful, diverse city of Peterborough. And it is extremely lucky of me to have a very honourable guest on my show, which I will be introducing, and he's got a lot of accolades to his name as well. But in the meantime, I would be extremely grateful if you want to participate. You know what the number is. It's Peterborough's code 01733602133, or you can text and WhatsApp us on 07745 278 978. We are also on Facebook Live, YouTube Live, Twitter Live, and we're also on Periscope. And this is the wonderful, what I call army of volunteers that we have behind Salam Radio, who are doing their best to build bridges with the community, portray a wonderful, positive aspect of our beautiful religion of Islam, and as well as talking about the issues that are pertinent today. I'm Dr. Shabina. I'm a local GP within the city of Peterborough. I love what I do. Being a GP is the best job, and I think that's the only job that I know how to do best. It's been a very tough day at work today and a very busy one, but I'm always here because this is my little me time, and it gives me the opportunity to be able to talk to you all. Now, without further ado, I would be absolutely privileged to introduce my guest, who is Mr. Asad Qayyum, who's a consultant otologist and paediatric and general ear, nose, throat surgeon at the Peterborough City Hospital. He is also the head and neck director of the North West Anglia NHS Foundation Trust, which comprises of the following hospitals: Peterborough, Stamford, Doddington, Ely and Hinchingbrook. Prior to his appointment at Peterborough, he worked as an ear, nose, throat consultant in Scotland. He completed his junior ENT training at the St Mary's Hospital in London and was appointed as a Specialist Registrar in ENT on the East of England training scheme. Asad's also performed research on the genetics of hearing loss and spent a year at the Sanger Genome Institute in Cambridge. Asad was appointed the International Otology Fellow at the Royal Darwin Hospital in the Northern Territory of Australia, where he specialised in advanced stage ear problems. On his return to Australia, he has spent time on the Otology Unit at the Addenbrookes Hospital, formalising his overseas training and learning the skills of implantation in children and adults with hearing disabilities. I've been told that he enjoys all facets of ENT surgery, but his special interests are snoring and sleep disorders, voice disorders, allergy, nasal, sinus problems, sinus surgery, nasal surgery, throat swallowing problems and neck lump diagnostics. Mr. Asad Qayyum, Assalamu alaikum.
Wa alaikum assalam. Thank you for having me on your show.
It's absolutely wonderful that you could make time on our show and to talk to the people of Peterborough, talk to them about all these ENT issues. And
thank you.
We were discussing just before the show about what we're going to be talking about, and that was paediatric ear, nose, throat problems.
Thank you. Yes, that's what we discussed about.
Well, I believe that there's somebody who works in Peterborough who's got a very similar name to myself that you're very close to. So I like to ask this question from all of my guests, Mr. Qayyum. And what I'd like to ask you today is, what motivated you to go into ear, nose, throat and head and neck surgery, please, if you could tell our audience?
That's a very long story. So if I can briefly give my background, you know about it, for your audience. I actually hail from a family of doctors. My grandfather was a consultant surgeon to the Valley of Swat, the ruler of Swat, and he did his fellowship as a surgical trainee in the United Kingdom in 1920s, and then returned back to serve in the Pakistan Army and subsequently in the Valley of Swat, where he founded the first hospital. My father himself was trained to be an ENT surgeon, so I saw ENT in my house at a very young age, and he and himself trained in the United Kingdom in the early 50s and returned back to Karachi to be appointed as an associate professor at the Civil Hospital and Dow Medical College, which is now the Dow Medical University. He was the third ENT consultant in the whole of Pakistan and trained doctors in the city of Karachi for 32 years of his life, from 1956 till 1988 when he retired. He passed away in 94, and during his lifetime, I actually never wanted to do ENT. And after his death, I was posted on the ENT firm, where I, probably because I had heard about ENT all my life, developed an inherent passion. And I think it was 4th year in medical school where I decided I want to be an ENT surgeon and pursued my passion. And here I am today.
Yes, here you are today with so much that's been achieved. And I know that you have a very proud patient pool and a family behind you, which is, it's endearing. I know that I have seen patients that have spoken about you and your achievements and your patient bedside manner. So you are very loved in the city as well, Mr. Qayyum. So thank you very much.
Thank you very much.
Now, what we're going to talk about today, Mr. Qayyum, is paediatric ENT. And what comes into my mind as a GP is paediatric ENT with regards to ear problems, tonsils, and we know that the budget within the NHS is getting tighter and tighter every year. So it would be wonderful if we could give a bit of an insight to our listeners about this. So I've got Sister Ruxana Qasr who's joined us. Assalamu alaikum, sister. Thank you very much. You are a wonderful supporter of my show. Sister Shazi Iqbal, Brother Shahzad, Ruxana Qasr, Brother Shahid, and Sister Maryam Mahmood. And we also have, we've got many other people that have joined us, which is wonderful. So before we move on, Sister Ruxana has asked us a question. Salam, sister. How lovely of you to introduce us to your husband. I have a simple question. My daughter's ears are blocked with earwax. Any suggestions? We do have a wonderful suggestion. We will be taking advice from the expert about that, Sister Ruxana. So I'm very glad that you've asked us that question. What we will be talking about is various ENT problems. So, Mr. Qayyum, can we start off by talking a little bit about otitis media, which are ear infections that children get? How is it caused and what's the treatment for it, please?
So, the commonest ear infection that is prevalent in the pediatric population, in the medical jargon, it's known as otitis media or otitis media with effusion. In the common language, it's known as glue ear.
Okay.
So this is, if I could give you the statistics for this, this is essentially present in 80% of the pediatric population, which is in the first 10 years of their life, will have at least one episode of glue ear.
Okay.
And 80% of this group is going to resolve within 3 months, essentially before even parents realize that their child has got a hearing problem.
Okay.
It's only the 20% who end up seeing the GPs, and out of those 20%, by the time they come to see a specialist, we only are left with the 10% of them. So it's a very small minority, but the problem here is that the patients who are left with glue ear or fluid behind the eardrum do suffer, especially from the point of view of speech issues and learning. And we all know that education and linguistics are essentially very important in the children in the early developing years of their life, because otherwise they feel they'll be left behind in their education.
Right. Okay. I'm sorry to interrupt you. We have a caller on hold. It would be wonderful to take their call. So, Assalamu alaikum. You are live on Salam Radio, and this is the Body Health and Mind Show. Who's speaking, please?
Wa alaikum salam. It's Akil Khalil.
Oh, Assalamu alaikum, brother Akil. How are you doing?
I'm very well, thank you.
So I hear some mischief.
You've got the lovely doctor on tonight, so I thought I had to ask a question.
Please do go ahead.
Thank you.
Okay, so Assalamu alaikum, doctor.
Assalamu alaikum.
Previously, in the 80s, certainly in the 80s and the 90s, it was regular practice for tonsils to be taken out, especially at a young age. But what I've noticed, certainly in the last 5 years, it's not normal practice anymore. Is there a reason for that? Is there a medical reason for that?
Well, let me answer that question for you. So if we talk of 80s, you're absolutely correct. Not only in 80s, in the years gone by, the evidence behind medical practice has been not as strong as it is now. In other words, we look at something known as risk-benefit analysis. So you look at the risk of the procedure and the benefit that the procedure will give to you. Now, the benefit can be benefit in kind and in quality. Quality means will the procedure actually have a benefit in improvement of the quality of life of the patient? And in kind, if it's an adult or a child, how much financial loss has that child or an adult incurred because of losing out? So when a child is off at home, obviously the parents stay back at home, and that's a financial loss to the system because the patients have taken time off. And similarly, if it's adults who don't go to work, that also incurs a financial loss to the system. At the same time, what is the cost of surgery to the National Health Service or to the individual who's paying for it? On that basis, the hypothesis that was achieved was that if an individual is suffering with more than 6 to 7 episodes of tonsillitis in 1 year, then the person is suffering bad enough that he requires removal of tonsils, and this is backed by evidence in the literature. But if the frequency of episodes is less than this, then the individual doesn't warrant intervention. However, they have elaborated on this, so it's 6 to 7 episodes in 1 calendar year, 5 episodes in two continuous calendar years, or 3 or more episodes for 3 years or longer. And that is when the patient will truly benefit from surgery in the form of tonsillectomy.
Okay, great, wonderful. Thanks for answering my question. And to Dr. Shabina, wonderful show.
Thank you very much, Brother Akil. Thank you.
Thank you very much.
We can't wait for your show as well. Coming on Friday about cars. We have a car person here in front of us.
It's right, exactly. I understand that's right, actually. So that's Friday night, Slam Radio, at 9 to 10 p.m. Geared Up.
Definitely.
Inshallah.
We will definitely tune in. Thank you very much, Brother Akil. Assalamu alaikum. Assalamu alaikum.
So I'll go on to answering my initial question about ear infections.
Of course.
I'll continue with that, sister. Sorry, I stopped to answer that specific question regarding tonsillitis. But with reference to glue ear, that's the commonest infection.
Right.
That affects the hearing. And when you come and attend the hospital, we then do a hearing test. And if the hearing loss is confirmed, then we proceed to put grommets in the ears. Having said that, there are certain children who will develop an episode of a bloody discharge from the ear. This is known as an acute infection, and these infections are almost always viral in origin, and they do not require, and none of these infections require antibiotics, and the discharge from the ear usually settles down within a day or two, and it is a self-resolving condition. If the child gets frequent attacks of painful discharge from the ears, that warrants an appointment with a GP surgery and a subsequent referral to the hospital to see the specialist.
Okay, and can we just, for information to our listeners, when would a child with otitis media, with discharging ears, warrant antibiotics? Because this is essentially viral, isn't it, in origin?
The discharge from the ear, which is an acute episode, preceded with pain in the ear. So the typical history is you've got a young child, he wakes up in the middle of the night, he's upset, he or she is crying, they have a little bit of temperature, the ear discharges, there's blood-stained discharge, and immediately afterward the child goes to sleep, and that's the end of it. That is of viral origin. However, if you have a child who continues to get smelly discharge from the ear, that means more than that. That means probably a hole in the eardrum or something called a cholesteatoma, and that definitely warrants a review by a specialist to look in the ear.
Would such children be suffering from temperatures as well, Mr. Qayyum?
The children who get recurring smelly discharge from the ear, which is painless, will not suffer from temperature.
Okay, so that would be implied to be viral, is that correct?
The one where it's painful with fever, one-off episode, is viral.
And what if those symptoms, because I often see patients that present to me more than 7 days who have said, they've really been crying, their ears are hurting, etc. We've done everything, we've given Calpol. Is there a time limit by which an individual should say, well, actually, I should be giving antibiotics, or would you still not suggest that, more than a week?
Unfortunately, as much as the myth is that this is of bacterial origin, ear infections almost always are of viral origin, and there's plenty of evidence in the literature to support that, and you don't need antibiotics, and they almost always settle on their own.
Okay. Well, that's fair enough to ask. I remember when being in medical school, and this is way back when we didn't have to worry about antibiotic resistance, and I believe I can be quite open when I say this to you. We had a paediatric consultant who said to us that when you get ear infections, they can go two ways, either down or up to cause meningitis. Now, as a GP seeing children, we're all aware of the implications of antibiotic resistance, etc. But what our biggest fear is, and in terms of protecting ourselves, is the fact that we don't give antibiotics and a child would then go on to, say, God forbid, meningitis or even sepsis. How long is too long to be left for a child to be having symptoms? I think that's the main question I'd like to ask you.
So, Dr. Shabina, on this specific question of yours, you are right, that the infection from the ear goes two ways, either up or down. I think it's not as common as it is quoted to be.
Right.
It's a very rare thing.
Okay.
And if the downside of this argument is that for children who were to develop, or adults even, who were to develop not meningitis but brain abscess secondary to an ear infection, will develop so in spite of antibiotics. And I've recently, literally this week, had a young lady who was in the 20s, and in spite of some very heavy duty antibiotics, still ended up developing a brain abscess.
Oh, goodness.
So what I'm trying to say is that antibiotics will not stop that infection. However, if the infection is continuing for almost 2 weeks, then I would suggest that intervention with the form of antibiotics to prevent a secondary bacterial infection is probably the way forward, though the jury is still out on this.
Okay. Well, that's very specific, and I think that gives us quite a lot of direction in how we're supposed to manage our patients. We see an awful lot of ear problems and fevers and temperatures in unwell children, I think, given the time of year that it is, and also the fact that, sometimes you just see a child who looks so unwell that you'd either send them into hospital but would think, you know what, I'd rather give a course of antibiotics, but obviously justified. Now,
This is an individual clinical judgment.
Sure.
There is no blanket statement for this. It's an individual judgment of that specific patient, and then you are left to decide as a doctor.
Okay. Well, that's very straightforward. So thank you for enlightening the listeners on that. So Sister Ruxana, coming back to her question, has asked, my daughter's ears are blocked with earwax. Any suggestions? And keep up the good work.
Thank you. Yes, the best form of treatment for earwax is using sodium bicarbonate drops. They are available over the counter from Tesco, Asda, Sainsbury, any pharmacy, by the name of Otex or Earex, E-A-R-E-X, Earex or Otex drops, or simply go to the pharmacist and say, I want sodium bicarbonate drops. And if the child has got wax in the ears, I suggest using 2 to 3 drops in each ear for 2 to 3 times a day for at least 3 to 4 weeks. What will happen is, when you initially put the drops in the ears, the wax absorbs the drops and swells up. The child may complain of a little bit of earache or may even cry with the pain. Please do persist with the drops, and you will realize in a few days the wax starts to come out.
Okay.
And initially the hearing drops, but then the hearing gets better immediately. And in 3 weeks' time, the wax completely disappears.
Okay. Well, that's a tip actually I picked up from you, because we have a lot of children. I must say that I have advised patients to put in a little bit more than 2 to 3 times a day. I've got, with hard stony wax, I have said, well, you can go up to 5 times a day.
Absolutely.
As well.
5 drops 5 times a day.
So 5 drops 5 times a day. And that can get rid of, I remember you stating once that it will get rid of the most worst clogged up wax. And they won't need syringing or microsuctioning. That's wonderful. So, Sister Ruxana, I hope that that has helped with answering your question. We've had Sister Hina Ahmed. Hello, salam. Wa alaikum assalam. Thank you very much. And we have Brother Shahzad. Assalamu alaikum to you, Shabina, and to your guest, Dr. Asad Qayyum, which I would love to meet outside his profession, inshallah. What would be your most memorable moment in this long and elaborate careers of yours that would stick out the most to you? This is what the question that Brother Shahzad is asking you, Mr. Qayyum.
Oh, that's a difficult one. There are lots, actually. Very difficult to put a finger on one specific episode in my career. I think one that really comes to my mind is a 13-year-old girl. I was a junior doctor in London at the St. Mary's Hospital in Paddington. And we had a young girl, 13-year-old. I still remember her name, Layla Ali, Middle Eastern origin girl. She came into emergency department after having her tonsils removed and was bleeding as if somebody had turned the tap on, hosing. And I remember I called my registrar up and said, look, we've got this patient. We need to get her into theatre. And my registrar said, I'm on my way in, but I'm stuck in a traffic jam. Put your skates on and sort it out. And I remember I took this girl to theatre, and by the time the registrar walked into the operating theatre, the girl was sorted and we were waking her up.
Wow.
And I remember the father and mother of that girl, the gratitude they had. I don't think I can ever forget the look in their eyes ever in my life. So that's one episode that really... I always think of it, and I often think of that girl. That I'm talking 2001 too, so 17, 18 years ago, and I do think of that girl and pray for her every now and again when she comes into my mind. She must be a grown-up young lady by now, probably a doctor, I don't know.
Yeah, well, you essentially saved her life, which is wonderful, and she may even have a family of her own, so
probably by now, ages ago, yes.
Very humbling, and it's wonderful, these little tricks that you learn through being an ear, nose, throat surgeon, because I've got a background of ENT surgery as well, as many of you may know or may not know. And I think the most striking moment for me of putting my skills into use was the time where my daughter got something stuck up her nose. And usually you have to take the children to the hospital to get it fished out. And sometimes, in some cases, the children have to be put to sleep. And I learnt this hack that I had to cover her mouth with my mouth, and I blew as hard and as fast as I could, and whatever it was just shot out and it hit the wall with a ping. So yes, that was when my skills were put to good use as well. Now, I've got some wonderful comments here. Brother Shakil Puri, amazing and on-point professional info. Thank you to the fabulous presenter and the talented participant, Dr. Asad Qayyum.
Very kind of you, thank you.
And we have Brother Chaudhry Rustam Suleiman, who has joined. Assalamu alaikum. We have Brother Azhar Chaudhry, Dr. Azhar Chaudhry, again my GP colleague, a wonderful GP in Peterborough, who has joined, is saying, Assalamu alaikum, Asad Bhai, great show.
Thank you, wa alaikum assalam.
Please discuss the treatment of post-nasal drip.
That's that's a great question. So the question is postnasal drip. Now,
what is it, first of all?
What is postnasal? So postnasal drip is essentially the mucus dripping down the back of the nose.
Okay.
Now, the question we have this question almost every day thrown at us by the patients. The problem is, when is postnasal drip normal and when does it become pathological, so problematic? The nose and the sinuses secrete about 2 liters of mucus in a day. Where does it go? It goes down the back of the throat and we swallow it and it's recirculated. So when does it become troublesome or problematic? If it starts to have a funny taste, a foul taste, or if you start to have, if it develops a foul color, dark greenish or a color, or people around you can smell it, that means it's an infection and it needs treatment. On the other hand, there are signs of it can be because of allergy. So it's not a bad idea to start the individual on nasal steroids to help with that and do an allergy test. Other than that, I would classify this as a normal variation of normality. And lastly, one thing which has always gone unnoticed, that a lot of patients have actually got symptoms of acid reflux, and they have developed reflux related rhinitis. So do not forget to ask them if they've got reflux, because just commencing them on simple things like Gaviscon Advance can actually help resolve these symptoms.
So we're going to continue that just after the break. I'm going to give a shout out to two brothers who I was talking to before the show, and he's just joined him with his wonderful hairstyle, I can see. Join us after the break.
Stay tuned to Salam Radio after this short ad break.
1 in every 10 people live without access to safe, clean water. Let's give them a better choice than drinking either dirty water or no water at all. Together, we can turn this desperate situation around by delivering safe water solutions to the world's poorest people. Call 0161 225 0225 or visit humanappeal.org.uk.
Where can you get high quality and low prices? Amar Food Store and Halal Meat in Lincoln Road, Triangle is the place to go. Pay us a visit and take advantage of our special offers and great range of products on groceries, vegetables, fruits and halal meat. Also send money to Pakistan absolutely free. We have all top brands at special offers, offer free customer parking and provide a free local delivery service. Amar Food Store and Halal Meat, 613B Lincoln Road, Peterborough. Call us on 01733 687 374. High in quality, low in prices.
Peterborough just got a whole lot tastier. Five Lads Flame Grilled Peri Peri Chicken is now open. Bring your family and friends to Peterborough's first HMC meat selling restaurant. We are experts in grilled chicken, lamb chops and gourmet lamb and beef burgers. Our healthy options include fresh salads and fresh grilled vegetables. Fresh, clean and healthy grilled food with 4 different flavours: lemon and herb, medium, hot and extra hot. 5-star hygiene rating. Eat in, order and collect or order for delivery on Deliveroo. Follow 5 Lads Peterborough on Facebook and Instagram 5 Lads. 15 Cowgate, Peterborough, PE1 1LZ. Call 01733 56 22 87. Open 7 days a week, 12 to 11 p.m.
Almarad Tiles. With over 70 stores nationwide, we are now open in Peterborough. Up to 50% discount offers now on. Largest selection of tiles. Full bathroom suites from only £189. Paint, LED lighting, laminate flooring from only £7.99. Over 1,000 designs of wallpaper in stock. We have everything you need. Come and visit us at 193 Fengate, Peterborough, PE1 5BH. Or call us on 01733 34 58 47. Almarad Tiles, now open.
الحديث 23 عن أبي هريرة رضي الله عنه قال قال رسول الله صلى الله عليه وسلم إن الله يقول يوم القيامة أين المتحابون بجلالي اليوم أظلهم في ظلي يوم لا ظل إلا ظلي رواه البخاري وكذلك مالك.
Hadith 23. On the authority of Abu Huraira, may Allah be pleased with him, who said that the Messenger of Allah, may the blessings and peace of Allah be upon him, said, Allah will say on the day of resurrection, where are those who love one another through my glory? Today I shall give them shade in my shade, it being a day when there is no shade but my shade. It was related by Al-Bukhari, also by...
This is Salam Radio, Peterborough's Muslim Community Radio. Broadcasting on 106.2 FM and online.
Welcome back. It's Dr. Shabina Asad Qayyum for the Body Health and Mind Show on Salam Radio 106.2 FM in Peterborough. Now, shortly before the break, Mr. Asad Qayyum, who's our guest, he is the ENT Consultant Surgeon for Peterborough City Hospital and also the Head and Neck Director of North West Anglia Foundation Trust, which comprises of 5 hospitals within the area. Now, before the break, Mr. Qayyum was talking about post-nasal drip and briefly how to treat it, etc. And Dr. Azhar Chaudhry has said thank you. So I hope that that was conveyed. Just before we move on, I would like to give a shout out to a very special brother of mine who I said I would, Mr. Star Abdul, who is probably sitting and watching the show along with my brother, Mr. Ali Khan, who are wonderful, wonderful supporters of the show and of myself. And it's endearing to have such support. So thank you very much, my brothers. May Allah subhanahu wa ta'ala bless you in all your endeavours. Now, Mr. Qayyum, thank you very much again for taking time out and giving your expertise advice regarding ear, nose, throat problems in children. And I have Dr. Aisha Durrani, who has come on board, and we all know how special she is, don't we?
Absolutely, yes.
She is. She's one of our favourites.
My special salam to her.
Yes, of course. And she trained me. So Dr. Aisha Durrani, may I please introduce to the listeners, was actually my trainer when I was a GP trainee. And she is still as young as ever. I don't know what she eats, but she looks exactly the same. And she's got grown sons, but she looks younger than I do. So she is saying, hi, Asad and Shabina, lovely show. I'd like to ask if you have any experience of the effectiveness of teaching GPs and how to do an Epley manoeuvre in GP land. And is it worth encouraging in GP? So first of all, would you like to explain what the Epley manoeuvre is?
So, Aisha, very good question. And yes, it is. It's very important if GPs know how to do an Epley maneuver because it saves an unnecessary referral. For my listeners on the show, Epley's maneuver is a maneuver which is performed in the outpatient clinic for patients who are dizzy. And this is specific to patients who are dizzy when they turn over in bed. To the right or to the left, and these dizzy symptoms would last specifically for 5 to 10 seconds, and that's it, and they disappear. So turning over in bed, right or left, or putting their neck back as if to pick up something from the top shelf, or bending forward is when they will feel that the world is spinning around them. I don't like to use the word dizzy, so they feel the world is spinning around them, and the spinning stops for in 5 to 10 seconds and everything is fine. And we do a special maneuver to get them on the bed, turn their head around, and it is resolved. So I shall get Shabina to send a video link to yourself and how to do an Epley maneuver. And next time when I'm having a teaching session, in fact, I'm happy to come to your surgery and give a teaching session on how to perform the maneuver live in some patient or one of the colleagues, which I hope that will help.
I hope that's helped Dr. Durrani, Aisha, and I hope it's answered your question as well. Now, moving on, talking a little bit, we also have a Mr. Tariq Mdeen. Salam, great show. What would you give in terms of advice to young medicine students? That is the question from the gentleman.
My advice is that medicine is it's not a short haul career. It's actually a career for life because your process of learning really starts the day you become a doctor, because that's when you're hands-on. So the important thing for you is to ensure that you are persistent and your perseverance doesn't stop. You have to continue, don't burn out. And the other important thing is that always make sure that you look after your patients. Your patients should always come first, even if that means going out the extra mile. Trust me, the satisfaction of that is so stimulating that it helps you go ahead and leap and jump forward. And finally, what I would like to say to you is read about people and meet the doctors who in your hospital, in your environment, in your surrounding are inspiring, because those are the ones you really will help you continue in your passion to become a good doctor.
Thank you very much. And I hope that that's been inspiring for some medical students who hopefully will be listening today, because this show is listened even internationally in Pakistan and even UK-wide, in fact. So that's wonderful. We've just had Amber Naqvi join. Belinda Speechley, hello. Wonderful that you could join us. Thank you very much. We have Najam Malik who has joined, and Brother Mohammed Hasib. Thank you very much for joining the show and listening in on the expert advice that we have that Mr. Qayyum is giving us today. Now, Mr. Qayyum, I would really like us to talk about snoring in children. We call it obstructive sleep apnea. Why does it occur? What are the implications of obstructive sleep apnea, and what can be done about it?
So,
what is it?
First of all, Dr. Shabina, I'd like to clarify to your listeners that snoring is not classified as obstructive sleep apnea. There is simple snoring where children snore, I snore, we all snore, a lot of kids snore. In fact, all children snore. If they're snoring, that's nothing to be worried about, even if it's loud snoring.
Okay.
However, if during their sleep at night, if the child holds their breath when they're asleep for more than 5 to 6 seconds, and it happens multiple times during the night, and in worst case scenario, they will hold their breath and wake themselves up during the sleep, that will be classified as obstructive sleep apnea. Typically, these kids will be very restless in bed at night. They will be difficult. They are difficult to be woken up in the morning. So when the parents try to wake them up, they're very difficult. And often the school complains by saying that this child is found sleeping during the classroom hours. And during the day, if you leave them in the house, they're found sleeping on a settee or on a sofa. These kids are classified as suffering from obstructive sleep apnea.
Okay.
Take a recording of their sleeping patterns, and when they snore at night and they hold their breath, show it to the GP, and they would warrant a referral to the hospital specialist, as they would require a review and possibly even surgery in the form of removal of the adenoids and tonsils if they're very large.
Okay. And what's the reason for obstructive sleep apnea? Why does it happen, and especially in small children?
So, as we all sleep, adults and children, the tone of muscles around the neck, the muscles relax, so the tone goes down. As that happens, these muscles collapse and make the oropharynx, or the back of the throat, quite narrow when we all breathe.
Right.
But in children who have obstructive sleep apnea, the tonsils are quite large and the adenoids are quite large. So when the side of the neck collapses, they find it difficult to breathe in.
Okay. And
that is why they block. And that's why during the sleep they would wake up in the night, or the sleep would be they'll hold their breath, and then the sleep would be disturbed. They will wake up, take a big gasp of breath or gasp of air, and then resume their regular sleeping pattern. And as the sleep becomes deeper, the breathing becomes shallower and then eventually stops, and then they wake up again.
Right. Okay. That's well understood. We have Andrew Robinson who has joined. Welcome, Andrew. It's wonderful to have you on board. And Brother Ahmed Bostan, who's joined as well. Welcome, brother. Wonderful. We're having a real, audience tonight. That's wonderful.
Thank you.
Yes, but it's because you've given so much to this speciality, and obviously it's an important one as well. I think every day within clinic, I can on average vouch to see at least 3 to 4 patients with ear, nose, throat problems. So it is a very important...
It is very common in the general practice world.
It is, yes, indeed. Now, coming back to the topics, Mr. Qayyum, we're talking now a little bit about the fact that adenoids, okay? Obstructive sleep apnea, coming to that as well. The implication of obstructive sleep apnea. Are there any implications, if left alone, on the heart with regards to obstructive sleep apnea?
Yes.
Or snoring?
Simple snoring will have no effect, but children and adults who have obstructive sleep apnea can develop multitude of problems.
Okay.
And the commonest of those is that the left side of the heart can become bigger inside. We call it ventricular hypertrophy.
Right.
And in adults, if left untreated, it can, on very rare occasions, be a source of heart attack as well.
Okay, right. In adulthood.
In adulthood.
So the take-home message really is that if you have a child who's waking up in the night and subsequently, as you say, during the day, teachers are complaining about this child being excessively tired, difficult to wake up in the morning, then that warrants a referral.
Yes, that's correct.
Now, what would entail you trying to fix that obstructive sleep apnea? Would it involve taking any tonsils or the adenoids out? What would you do?
So if we are confident that the history is suggestive of obstructive sleep apnea, it will require a good examination of the mouth, the throat, to make sure that it is the tonsils which are large, and it's the adenoids which are large. If the tonsils and adenoids are of a normal size, then we proceed to do what's called a sleep study, where the child is given a special monitor to sleep with to assess if their oxygen levels are dropping whilst they're asleep. And if that is confirmed that it is obstructive sleep apnea, then they warrant some form of an intervention, either in the form of surgery or otherwise.
And going back to adenoids, large adenoids, because when I was training as an ear, nose, throat surgeon, and then I changed my career to GP for obvious reasons, I remember that adenoidectomies or removal of the adenoids was also take place. What are the symptoms caused by enlarged adenoids, and what warrants a removal of them?
So the commonest indication for removal of adenoids is obstructive sleep apnea, followed by removal of adenoids when we are putting grommets in the ears for hearing loss. If they're blocking the mouth of the tube that equalizes the pressure between the back of the nose and ears. And lastly, they are also indicated, there's an indication to have them removed if the child has got a blocked nose, not able to breathe from the nose, and recurring episodes of head colds which last longer than 2 to 3 weeks. Because the back of the nose is blocked and not aerated.
Well, that makes sense. It definitely does. We have Brother Ahmed Bostan, who's asked a question and given some really kind comments. Thank you. Excellent show, and thank you so much for having such a brilliant guest. I recently had microsuction after a large build-up of wax in my ears over many years. I suspect my hearing capacity is only slightly reduced as a result of not treating this earlier. Can any hearing loss be restored? What do you think's happened to Brother Ahmed's ears, Mr. Qayyum?
So I don't think wax is a cause of hearing loss. Once it is removed, it's reversed and it is treated. However, if the hearing loss is persisting after the removal of wax, that means that either the bones of hearing in time have become stiff, or the nerve of hearing has become weak in time, which happens to all of us as we become older. I call it hearing loss of maturity.
Brother Ahmed Bostan happens to be younger than myself, so
it's not a bad idea to have the hearing tested, because the hearing test in itself will confirm if the hearing loss is because of the nerve of hearing which has become weak, where the treatment is hearing aids, or if the bones of hearing have become fixed, which can be treated by surgery.
Brother Ahmed, I hope that has given you some explanation as to why you may be suffering from hearing loss, but it would be a good idea to have a hearing test done first, just to see what type of hearing loss could have occurred. Is there any merit, Mr. Qayyum, in saying that with repeated microsuctioning, you can paralyze the little hairs in the ear canal that can cause any deterioration in hearing? Is there any theory behind that, or that's just me making things up?
No, that's a myth. Loud noises can give rise to hearing loss, and it's commonly seen in individuals who've been exposed to loud noises in their earlier life, but I'm talking very, very loud noise, louder than 90 decibels, 90 to 100 decibels, so like jet engines, etc., or people using sledgehammers on the roads, that level of noise, or motorbike riders riding a motorbike without helmets, at that level for many years can give rise to hearing loss, which is of noise. It's called noise-induced hearing loss. However, microsuctioning, no, it cannot.
Thank you for that. Now, I think in the last part of our show, it'd be important to talk a little bit about glue ear. So what are the typical, could you explain to our listeners in an easy way a scenario whereby a patient would be presented to their GP with a certain type of history suggestive of blue ear, and then it's found out that it actually is, and what that person's or patient's journey is there on when they come and see you, and what you would do about it, please?
So as I said earlier on in the show, glue ear is simply collection of fluid behind the eardrum.
Okay.
This is not infective.
Sure.
Let me clarify
So
that.
no infection.
No infection. And essentially, these children, parents will say that when they call for the child or, try to get the child's attention, the child will not respond to them unless and until they see the child or the child looks at the parents. Typically, the school will say that the child can't hear.
Yeah.
And there may be some delay in the education, learning capabilities of this child or learning capacity of this child.
Yeah.
And if this continues, then that means that they need to be referred across to the specialist like ourselves. We do a simple hearing test on these children, which will tell us that they've got a hearing loss and they have fluid behind the eardrum. And if this hearing loss persists for more than 3 months, because that is what the guidelines, the NICE guidelines are that we all follow from the National Institute of Clinical Excellence. If the hearing loss persists for more than 3 months, then we will intervene by doing what's called a grommet insertion. If the parents do not want grommet insertions, we can provide them with simple hearing aids as well, which are equally helpful and effective.
Right.
But when we go ahead and do grommet insertion, it's done under general anesthetic.
Yeah.
There's a tiny nick which is made in the eardrum, not larger than 1 millimeter in size, and a grommet tube, which is about 0.3 or 0.4 centimeters in size, is inserted into the eardrum to allow the drainage of fluid.
Okay.
And the hearing improvement is immediate, and it is a painless procedure.
That's wonderful to know. And when you say painless procedure, the child obviously has to undergo?
It's a general anesthetic. The child is put to sleep, but when they wake up, they do not feel any pain.
Okay, and their hearing is improved
immediately.
As well. That's wonderful. Now, I often see children that have presented to me after having grommets inserted complaining of, for example, that the grommet hasn't fallen out. In regards to swimming, which is often a very common question asked, whilst a child has grommets in, are they allowed to swim?
They're allowed to swim, but they're not allowed to go underwater.
Okay.
So they're not allowed to dive. As long as the parents are confident that the child will be able to swim on the surface and will not dive underwater, they are safe. They won't get any infections.
So are we saying, in other words, that a child should not have their ear, this part of the ear, inner part of the ear, exposed to any form of water, even whilst having a shower or a bath?
No, shower or bath. Shower is all right. Bath, again, they can't duck their head underwater. That's the important thing. Because the size of the hole in the grommet is so small that if you put a drop of water on it, it won't go through.
Okay.
However, when you're underwater, the pressure per cubic centimeter of pressure increases for every inch that you go under deeper. And then the pressure is high enough that even through the small hole in the grommet, the water pushes itself in, and that starts a discharging ear or an ear infection.
Okay, so that's something to be careful about, listeners. If you're listening, Mr. Qayyum has said that once a child has grommets, they can swim, but their head can't go underwater. Unfortunately, though, that there are some swimming lessons that take place in which it is part of the curriculum to see if that child can dunk their head underwater.
So we always we are happy to give a letter of support to the parents, and they can carry on swimming lessons but not put their head underwater. And to, just for the sake of safety, we tell parents to have cotton wool, just normal cotton wool, put a lot of Vaseline on it, make a cotton wool ball and put it in the ear canal to stop the water from going in, and wear a swimming hat.
Right.
That's just a precautionary measure.
Okay.
But still, that doesn't allow them to go underwater.
Okay. So a lot of what we've spoken about, we've covered quite a few topics, I must say. And actually, I think Brother Akil, who phoned in earlier on, sort of did mention tonsillitis. Now, within my own capacity as a GP, I think the thing that I do tend to worry about is that I've seen some very sick children with tonsillitis. And often it's difficult to give them medication because they aren't able to swallow. Now, do you see children with severe tonsillitis to the extent that actually you would think that taking these tonsils out would be in that child's best interest, especially, for example, if they're not thriving or they're underweight? Is there any indication that a child can have a tonsillectomy whilst not meeting the thresholds that you described before? And would you like to run through those briefly again, please?
So, the guidelines are, as I mentioned earlier, 7 episodes of tonsillitis in a year, 5 and 2 consecutive years, and 3 and 3 consecutive years or more. Or if the patient has had an abscess around the tonsil, we call it quinsy, where a needle has to be put in to drain the abscess.
Okay.
So these are the main indications. The commissioning groups, which fund the hospitals for surgeries performed in various parts of the country, have slightly different thresholds. We get patients from Cambridgeshire and Peterborough CCG, from South Lincolnshire CCG, from East Leicestershire CCG, and from Northampton. So we get patients from a very wide area, and there are always differences in the criteria. But generally, these are the general guidelines that they all follow. If we have to move away from the guidelines and do operation on an individual, we have to apply for something known as an exceptional funding.
Okay.
And that we write a letter to the CCG, who will then authorize or not authorize the surgery, and then we inform the patients of the outcome. They are happy to, patients are allowed to challenge the decision.
Okay, okay. Well, that seems fair enough. Now, Mr. Qayyum, if we can fit in very quickly, because we still have only 5 minutes, we wanted to talk a little bit about bleeding noses in children. How does it start off? What does it present like? And what would be the treatment?
So bleeding noses in children is because the blood vessels are quite superficial in the nose. It's common in means that they are very close to the lining of the surface of the nose.
Sure.
Bleeding in children is commonly from the septum, which is the partition between the two nostrils. It usually starts because the child has been nose picking at some stage in their life, and the crust, before the crust heals, they pull it off.
Yeah.
On other occasions, the blood vessel is very superficial and would burst from time to time.
Okay.
The treatment for this is to go and see your GP, who will provide you with an ointment that can be applied in the nose. If still that doesn't heal and the noses still continue to bleed, then you either need to go and see your GP, who may then want to cauterize your nose, or refer you to a specialist who can then subsequently cauterize your nose. Cauterizing the nose means that the blood vessels, which are very superficial in the nasal cavity, we use a chemical stick after applying local anesthetic or numbing the area to just burn those blood vessels.
Okay. And what are the causes of bleeding noses in children especially?
The commonest cause is just superficial blood vessels, because the blood vessels are very superficial in children.
Okay.
But on rare occasions, there can be other blood-related conditions which can come to surface simply by excessive nosebleeds. Okay. So a child who gets excessive nosebleeds and comes to a GP surgery will warrant a blood test to ensure that the blood numbers are within normal range.
Okay. Well, that's been very interesting to point out, and what I would like to ask you is that you've given the treatment by going to the GP. If a patient or a parent is faced with a child whose nose is bleeding in the last 2 minutes, what would they do?
They should pinch the nose of the child. So when I say pinch, it means pinching right at the bottom of the nose where the nostrils flare out.
Okay.
So the soft part, sit the child up, pinch the nose, and if you've got a bag of frozen peas in the freezer, bring it out, wrap it in a thin cloth, and hold it above the child's nose, so just above where the eyebrows are, and also periodically on the side of the neck, and also give some ice cold drink. All these measures are to basically reduce the intensity of blood supply within the nose, and that usually stops the nosebleed.
Okay, well, that was really informative, and I think hopefully we may have covered most of the ENT topics in PEDS as it is. I'd just really like to thank you for taking your time out and speaking about these very important issues. I think as a GP we see it very often. some parents aren't really aware of how to go about these problems. So
thank you very much for having me over, and I'd like to thank your guests who participated in this show and made it successful.
Thank you. Now, that was Mr. Asad Qayyum, who we have had on the show, who's an ear, nose, throat consultant for Peterborough City Hospital, and also the head and neck director for North West Anglia Foundation Trust that comprises of the 5 hospitals in the area. It has been an absolutely wonderful turnout by all of you today. I really am warmed by all of the responses that have come through and the interest that you've shown, and we've had some last minute pop-ups over here, so thank you very much for joining us. And as always, I'm hopefully going to be back next week, if I'm not unwell or anything like that, with another fully informative show on Salam Radio. This is the Body, Health and Mind Show every Wednesday at 7 p.m. It would be wonderful to have you. And we have Mr. Khalid Qureshi, who I've had on my show before, vascular surgery, or fit in, who said very useful information. Thank you very much. Thank you for your participation. And join me again next week with another Body, Health and Mind Show. Assalamu alaikum.
Assalamu alaikum.